Hi, good afternoon, everyone. Sorry, I'm a bit out of time. So, thanks, Harry and team, for inviting us to talk about this topic, achieving high diagnostic yield with non-robotic bronchoscopy techniques. So these are my disclosure, but the biggest disclosure is that I'm just a sour grapes without his robotic. I'm not against robotic, just that we don't have access to it. Yeah, so we'll just share our experience on peripheral bronchoscopy. So I'll just talk briefly on the lung nodules problem in Southeast Asia, how we optimize our steps in lung nodule biopsy, and of course, to share our experience. So I think everyone knows solid nodule more than 8 millimeters, the risk of malignancy is high. And in the Chest Asia guidelines, we favor less reliance on PET scan and also greater use of non-surgical biopsy because of higher prevalence of tuberculous nodule. So if we look at the TB prevalence from Southeast Asia radial EBUS literature, we can see that from Thailand, Singapore, and Malaysia, it ranges around 17 to 24.7% of tuberculosis. In Japan, Korea, it's low. It's 4.8 to 0.8 to 4.1 kind of data. I think that some data from India as well showing around 11.5% of nodules were eventually tuberculous. So I always like to talk about guided bronchoscopy for PPL. It's just like delivering a package to someone. So first, we really need to know our target, what type of targets we're dealing with, how are we going to sample it and stuff. So what device are we going to steer? We have ultratin, do we have robots, or we use guide shift, curette, etc. And then we need a map, how our navigation system, are we going to do it manually, or we use some VBN system or something like that. And of course, when we reach there, we need to verify, we are reaching the correct person. We can use EBUS, fluoro, COMBEAM, lung vision, etc., etc. And then, of course, after that, we have to do the actual delivery, which is the biopsy, which you can use brush, needles, forceps, cryo, etc. And after that, we really need to audit the whole procedure to see how good and we are performing. So briefly, I'll go through navigation. We can do it through manual bronchial branch reading technique. We can do all the automated system through various VBN, but all this will require money, which a lot of us doesn't have. So I really like this study. It's an Atlas study, which they look at the distance from the terminal end of the navigation pathway to the target PPL. You can know this is the earlier generation electromagnetic navigation, and this is the latest robotic navigation. And interestingly, there's always a gap around 9.4 millimeter in the latest robotic system. That's still a significant gap that the computer automated algorithm could not generate that pathway. So this is a case that we actually plan. So by just looking at the CT, we are able to map out all the airway that actually leads into the target. But if you put it on the navigation system, you can see there's actually 3 bifurcation that's missed. So if you're using a big scope and imagine you park your scope here, that's a lot of chance that we might actually miss the nodules, all right? So bronchial branch reading technique, I think we really have to say thank you to Prof. Noraki Kurimoto, who actually formed a very solid foundation for us to build, to do this navigation. So if this is his first book on bronchial branch tracing, if you translate directly to English, it basically means to translate CT images to bronchoscopic images. And then we just have to move like a ninja throughout all the small airways. So this is our earlier work on in 2019, around 100 patients. These are using big scope, a 6.2 mm scope with a guide shift and bidirectional guiding device. A big lesion, 2.67 cm. We can reach there by 98.9% of the time, but the yield is 88.8%. I'll have to say this cohort, we are using a very liberal kind of diagnostic yield. Those of you who know Prof. Kurimoto's method, mainly he's using Excel CT for planning. So over the years, I think we have developed, we find that in certain reconstruction, it's better for us to get to certain views. So I'll just show you one of the cases. This is a 55-year-old gentleman with a colorectal CA with a RI sac nodule. TB cultures, everything was, AFB was negative. So just by turning the CT in the appropriate location, you can see the arrow RB8, and it's split to A, B. So we just follow the B. It will split to like this, okay, 1 and 2. And then we follow the 1, it will split further to, this one, alpha and beta. If we follow the beta, it will go Again, it will split to X and Y, and then we follow through the X, you will see that it will split again. Somewhere there, yep, YX again, and then that small airway will actually go to the side of the nodule, all right? So when we do the scope with an MP190F 3mm scope, you can just follow the map that we have planned. So RB8, AB, 2, alpha beta, the beta XY. So now we are reaching the final destination, and you know there's only 2 bifurcation inside. You just put the radio probe in, and you get the solid radio E-bus image. And then we do a spin, we confirm that we are reached there, and then the cryobiopsy just confirm it's a METS colorectal CS, so patient can move on to the treatment. So I think using this ultra-thin scope, it really helped us to reach the nodule very, very well. So this retrospective data, 47 patients using MP190F 1.1 cryo, only based on bronchial branch tracing on the 1.91 cm median size lesion. We can reach there in 91.5% of the time. Index diagnostic yield, this is quite strict, it's 82.9. But if we allow some follow-up data, we can reach up to 91.5% of diagnostic yield. So next, we go to steering tools. I think this is very important when we consider. So either we are using a big scope, a diagnostic scope, a slim scope, or ultra-thin scope. Or you don't have this, you always can use a big scope with guide shift and curate. So curate is very important because it allows us to change direction. So if you see this photo in A, the radio probe will just follow this direction. But with curate, we're actually able to guide the guide shift into our desired airway, and then we can just biopsy. So it's very important when you're using big scope, you can use a guide shift to steer where you want to go. But again, we know if we can reach nearer to the lesion, it's better for us to biopsy because we give us a better angle, better distance and stuff. So of course, we love the ultra-thin bronchoscope. The MP190 from Olympus with a 1.7 channel really allow us to insert radio E-bus for verification and stuff. So I like this slide. If you look at the existing robotic system, this is the size of the catheter. So the ultra-thin is really quite comparable with the size and the channel and allow vision almost all the time, like what Dr. Amer has mentioned in the earlier talks. So this is the scope. These are the scopes that we have. So every case, we will choose which scope to use to have a better reach. So how about the literature? I think this is a very nice review article from Dr. Oki from Nagoya. The U with radio E-bus is around 41 to 86%. Radio E-bus plus COMBIM around 85 to 87%. So the overall U is around 70% with ultra-thin scope, but we have to be mindful that these are all mostly using small forceps. So of course the U will be lower. So our experience is that if you are using forceps, it's around 84, which is consistent. Cryo, we can achieve around 94.1. Especially be useful in those non-concentric lesions. I think cryo will perform better than forceps. Yep. So using ultra-thin is also allow us to have direct visualization. This is a patient with a right upper lobe nodules. You can see we can go all the way into that segment and we can able to visualize this lesion. So in the figure C, we get a complete blackout because this is melanoma. So when we touch our scope on the nodule, that's no light at all, right? So this is a quite interesting case that we report a complete ultra-thin bronchoscopy blackout due to a melanoma. But the problem, I think, of ultra-thin scope is the lack of rigidity. So in this case, maybe the robotic shift is better. So in Japanese, they are calling this the Watanabe phenomenon. It's especially when it's very angulated to the upper lobe region. So when we have this downward force, this force is not transmitted to the end of the scope, but instead the scope moves paradoxical retraction. So this is something that we have to be very aware of because it's very fragile. If you keep doing this, eventually the fibers will break and then you have to send for repair. But the easiest way to do this is just put in some stiffer forceps or radio probe to stiffen up the scope so that the scope can continue to move to a more apical region. So next, we talk about verification techniques. So we have probe-based and imaging-based method. prop-based, the most common one with radio EBUS. OCT and confocal laser, it's there, but it's not commonly used in routine clinical application. Of course, we have fluoroscopy, tomosynthesis, and cone-beam CT as imaging-based kind of verification. So radio EBUS, I think we do not need to talk too much. It's, the orientation is related to the airway that we have reached. But again, radio EBUS has a lot of issue. If there's a lot of problem, it's poor signal with ground glass nodules. If it's atelectasis, you can get some sort of solid lesion and stuff. And most importantly, you have to have contact. If there's no contact with the nodule, there will be no signal. So the next one is about fluoroscopy, but we also know the limitation of fluoroscopy. For small target, we have very poor vision. Non-solid or ground glass lesion, very poor vision. And of course, in overlapping areas like the retrocardiac, diaphragm, paraspinal, we can't really see. But of course, we always use the fluoroscopy to mark our radio EBUS. So we know the proximal and distal end. So sort of like a manual augmented fluoroscopy to allow us to perform biopsy in that region. So recently also we start to use this virtual fluoroscopy. By just using normal DICOM software, you are able to plan how are you going to rotate your C-arm during procedure instead of just try and error during the actual procedure. So this is a case where the nodule is hidden behind the diaphragm. So I expected if you are using AP fluoro, you are not able to see this nodule. But if you're able to just rotate and pre-plan your fluoroscopy, at the RAO of 25, you are able to open up the angle, you can see the nodule nicely. So I think this is one way to optimize our fluoroscopy instead of just keeping at AP all the time. So we get the diagnosis of this case. So it's also important for those lesions that it's invisible on fluoroscopy, like this case of part solid nodule. So by doing this pre-planning, we're able to sort of localize where the lesion is. So during the actual procedure, we have a rough idea where's the target and where for us to put our tools. So virtual fluoroscopy is something that the Japanese use quite a lot, especially in Tokyo. The NCC Tokyo have published quite extensively on this topic, which has shown that for GGN invisible on fluoroscopy, this technique actually able to increase their diagnostic yield. So how about 3D intra-procedural imaging to help us in this? We have body vision. I have no experience. We have cone-beam CT. This is a very nice image from Dr. Tajali. I really love it. It's small, very small GGN at apex. It's really just amazing. So I think meta-analyses have shown that cone-beam CT is able to increase the diagnostic yield of our procedure, be it ultra-thin scope or in electro-navigation bronchoscopy. So it's especially good in those lesions, I think, with GGN that is not visible on radio EBUS. So we have a case, part solid nodules in the right upper lobe. So we can navigate there. If you put in the radio EBUS, you will get some sort of mixed blizzard kind of signal. It's not easy to identify, if you are just starting to do radio EBUS. So sometimes you don't feel confident to biopsy there, so it might be difficult. So if you have other imaging modality to help in this kind of situation, it might be helpful. So recently we have a case of pure GGN in the left upper lobe. So when we put in our radio EBUS, you can't get any signal as expected. It's not even, a specks of blizzard or something, there's nothing there. So fortunately now we have a mobile cone-beam from the ZIM system. So when we do it, after navigate with bronchial branch tracing, you can see that the two go directly just next to the target. It might not be very clear, sorry. So on this view, we can see our probe is really just parking next to the ground glass nodule. So in this case, the cone-beam actually able to convert a low confidence radio EBUS procedure into a high confidence localization. So when we do a cryobiopsy, it's proven to be a lapidic adeno-CA with positive EGFR. So patient is waiting for resection. So these are the things that we get, the specimen that we get from the cryobiopsy. The first pass actually, when we examine properly, you see some cartilage here, but it's normally just normal lung parenchyma. But in the second pass, we're able to get a lapidic kind of adeno-CA. So when we check our first spin, it actually just is not within the nodule. And the second spin, after adjustment, we can see now we are really just touching the nodule and get us the answer. So now we are start to do all this combined spin with our radio E-bus. So yeah, it's really quite interesting. But we are really interested to know which type of cases really we need for diagnostic indication, which we don't think we will need it for every case. So just now we talked about verification by prop-based, by imaging system, but I think the extreme miniaturization of tools allow us to do verification on direct vision. We have the zero scope from Vatin, which 2.2 mm allow us to go very deep in. We have the iris scope with 1.8 millimeter, and even the Japanese have described a 0.97 mm fiber, which they can really reach very, very distal part of the lung. So we're doing this with a Vatin zero scope. You can see how far we can reach, to the distal airway. It's really amazing. So we can really just reach the subpleural region, and this is the 2.2 mm scope. So if we can develop a shift that's quite flexible, that we can drive, then it's going to be perfect. So next, briefly on biopsy. How are we going to do biopsy once we reach there? We can do lavage, brush, needle, forceps, or cryo. That's a lot of things for us to choose from. So we have a patient here with sigmoid colon CA, post-resection and chemo with a 0.7 mm nodule up there. Not sure this is TB or just another cancer or metastatic or something like that. We're able to reach there, we get some signal. We just do lavage because I think the pretest diagnosis for this patient is, it's more towards TB. So as expected, we get a gene expert positive and then cystatin granuloma on forceps biopsy. So as I mentioned in the first few slides, the TB prevalence is very high in our region. So we try to sort out what are the predictor factors. So like age, younger age, smaller size, upper lobe cavity with radial EBUS bronchogram, probably quite predictive of tuberculosis. But of course, this is in the context of our region where we have 112 per 100,000 population TB incidents. So how about not lavage? How about using needle? I think it's useful in lesion without a bronchus sign. The problem is the stiffness of the needle and the cytology specimen that come with needles. So using a guide shift and needle, as you can see this case, our probe is just moving away from the nodules. There's no direct airway that go into the nodule. So with a needle, we are able to puncture in and put the guide shift in to allow us to do effective biopsy. So of course, the Peripheral flex needle, which we can use with the ultra-thin scope, I heard it's going to be launched this afternoon in India. So this also allows us to make a direct puncture. You can see after puncture with the 21 gauge Peripheral flex, we were able to get a hole on the airway. All right, so we will just put in the radial EBUS probe into that hole, and then you get a very nice concentric image. Yeah, so then you can put forceps, cryo, whatever in to get a biopsy. Another very good needle is from the Bronchus. This is a second generation Bronch-True BTPNA kit. It's a tapered end a sheath with a needle tip that allow us to really just tunnel in, tunnel the sheath into the nodule. So convert from a pure adjacent into a within orientation for biopsy. Yeah. So to know more, I think we can, I invite everyone to read this article from us, the technical aspect, how we plan it without other navigation system. So this is a very good needle from Olympus, the Smooth Shot Plus. This is a very flexible sheath and just a needle tip. So this allows us to go into all your 4 mm scope and reach upper lobe to do all the puncturing. So how about cryobiopsy? I think this from Prof. Felix Herf and the Shanghai group have shown us the diagnostic yield is 91% in a very large cohort of patients. Basically, it gives us very huge specimen intact architecture for pathological analysis. So we have also shown in 2019, I think, that the cryobiopsy actually have no difference if you get a concentric image, but if you get eccentric or adjacent image, it's actually increased the diagnostic yield significantly from around 50% to 75%. So bleeding is more common, so we will advise to use it not in every case, only in indicated cases. So most of us are using 1.1 mm for nodules. So how many pass, how long to freeze, I think that's no guidelines. But when we do a historical comparison of our cohort using 1.9 versus 1.9, we find that the freeze time around 6 seconds with 3 passes, that usually to be adequate to have a comparable diagnostic yield with the historical 1.9 millimeter probe. So cryobiopsy techniques for PPL, you can do the standard on-block technique where you activate and you remove the whole scope with a balloon, or you can do the shift retrieval method. You just retrieve quickly the 1.1 mm probe through the guide shift or your scope. But we don't really like the shift retrieval methods. Our experience is that if you're using that for cryobiopsy, just using cryobiopsy alone, the yield is around 60%, but if you combine with forceps, it's around 85%. So the Tokyo group have shown very good data. They're using the 260F scope, which is the P190 scope, no shift. They'll just pull the cryoprobe from the working channel, and very good diagnostic yield of 82.3%, despite smaller specimen size compared to conventional methods. And they report there's no bronchoscope breakage. So those of you who have went to Tokyo before, you know their bronchoscopy rack at the back is full of scope. So I think it's okay to have one scope breakage, but not for us. So I'm not going to sacrifice my scope using this technique. So when we're doing cryobiopsy, I think have been shown multiple times in a lot of paper. The first cryobiopsy is the most important biopsy, because after that you will have issues, whether you are blocked by bleeding, you are blocked by whatever things. So why is that so? I just want to show you this very nice case. So it's an upper lobe nodule that we drive it with an ultra-thin scope. So we can see we are in the lesion, so we are very happy. So we do a spin, everything is okay. So radial probe is 2 in lesion. First pass at second, very good tissue obtained. Second pass at second, there's no tissue. So we got worried, is it because our navigation fails or something like that? So we put the cryoprobe in and we do another spin. Now you can see after 8 seconds, you can really see a big hole in the nodules. So I think that's the reason, at least we think that's the reason, because now after cryobiopsy, you leave a very big hole, and we're using a 1.1 mm probe, so the contact might not be good. So fortunately, the first pass already gives us an answer, so we do not need to proceed further. So I think the Japanese also do a lot of this negative pressure expansion, especially when they are biopsying for ILD or biopsy for ground glass nodule. So this is what we usually do as well. We just put it into a syringe and then we apply around 10 to 20 cm water of suction just to expand it, then before we throw into the formalin. Yep. So I think the last part is how we audit ourselves. We cannot just keep doing and say we are very good. So this is our experience over 6 years. We divide our experience into 5 batches, around 100 patients per batch. So the overall diagnostic yield is around 78.8%, very high prevalence malignancy, 62.7%. Pneumothorax risk is 1.1%. So if there's a bronchus sign or concentric radial EBUS, it's a predictor for a conclusive procedure. So how about in the future? So if we're talking about integrating ultra-thin bronchoscope into our practice. So by this paper from ours is around 91.5%. So maybe it's get better. So now with COMBIM CT, is it getting better? We are not sure. So we are currently recruiting our patient into the COMBIM registry. And hopefully in 1 or 2 years, we're able to know which type of patient actually need COMBIM CT, or you can just use your bronchial bunch tracing and radial EBUS, they'll be good enough. So the take-home message from me is, I think radial EBUS without additional automation technology, at this moment is still relevant and an elegant tool for accessing lung nodules. We have to maximize the potential of our current tools, and then the development of technology in various aspects of guided bronchoscopy for lung nodules, in navigation, in robotic, in verification technique, biopsy technique, along with advancement in therapeutic ablation is highly promising and exciting. So don't compare ourselves to others, but always focus on getting better at our own performance. That's what we believe in. So lastly, I think just allow me to advertise. So in August 2025, we're going to have our EBUS and cryobiopsy workshop in Malaysia. I think Prof. Poletti will be there with us. And of course, our MABIP annual congress will be in the beautiful city of Malacca. So I hope everyone, if you are interested, please join us. So thank you from my small team in Sarawak, Malaysia. Thank you.